Well, thank you for inviting me to speak to you tonight in these unusual circumstances. This is the first time I've actually done one of these webinars, although a lot of my talk tonight is actually based on a webinar that I did a month ago with Harvard University. They have a postgraduate course in endocrinology, so I would like to acknowledge the course material from Harvard, which fortunately for me was online, and I didn't have to physically go to New York and Boston 4 weeks ago. And just for completeness, before I launch into the presentation, I have no disclosures. So we're covering a lot of ground tonight. I'll try and get through it as quickly as I can, and I encourage questions. The first section is on thyroid disease, and there'll be a break at the end of that for any questions relevant to the topic of thyroid disease. So this is the overview of what we're doing tonight. We're going to look at thyroid disease in pregnancy because this is an evolving hot topic, and there's a lot of controversy and confusion about this. Hypothyroidism, hyperthyroidism, the thyroid nodule, because a lot has changed in our assessment of thyroid nodules in the last few years, and I'll show you our current system for evaluating the thyroid nodule, and then we'll finish off with a bit of osteoporosis and osteopaenia. So just looking at thyroid disease in pregnancy, I think this slide highlights the notion that it's probably easier to tell you who not to screen for thyroid disease in pregnancy. There's a very broad amount of indications for checking for thyroid disease, but some of these are interesting. So women with unexplained infertility, because thyroid disease is a recognised cause of that. Women with a prior history of miscarriage and preterm delivery, it's certainly reasonable to check for thyroid disease and thyroid antibodies in that situation. And the rest of them are all pretty self-explanatory, I think. Just starting off with hyperemesis gravidarum. This is a common situation in early pregnancy that all of you as GPs would be familiar with. And about 2/3 of cases are associated with abnormal thyroid function. And these women often have a high free T4 and a suppressed TSH. Interestingly, in this situation, the T3 level is usually low to low normal, and this is because of poor nutritional status associated with the hyperemesis. And this is mediated by HCG, which has a TSH-like action. And occasionally, in particularly severe cases, we need to treat this with anti-thyroid medication, but I emphasise there's a paucity of medical literature related to this. And it can be quite difficult to distinguish it from true thyrotoxicosis, and this is a common source of referral to an endocrinologist. So what are the potential distinguishing features of true thyrotoxicosis versus hyperemesis? Well, the increased likelihood of thyrotoxicosis if there's a prior personal or family history of thyroid disease. Typical symptoms of thyrotoxicosis: the presence of ophthalmopathy or pretibial mixed edema is significant because this increases the likelihood of underlying thyroid disease. A significant resting tachycardia and increased pulse pressure increases the risk of or the likelihood of thyrotoxicosis as opposed to hyperemesis. And of course, if there's structural abnormality of the thyroid gland itself, that increases the likelihood that you're dealing with a case of thyrotoxicosis. Okay, so if a patient has hyperthyroidism in pregnancy, 95% of this is due to Graves' disease. I've seen a couple of cases of nodular disease, painless thyroiditis, and I've seen one case in 30 years of molar pregnancy causing thyrotoxicosis, this HCG mediated. If you don't treat hyperthyroidism in pregnancy, it can increase the risk of miscarriage, preeclampsia, premature delivery, birth defects, and low birth weight infants. Of course, thyroid nuclear scans are contraindicated in pregnancy, but ultrasound may be appropriate, looking for nodular disease in particular. And important to look for evidence of Graves' disease with TSH receptor antibodies. ESR may be elevated in thyroiditis. And in terms of Graves' disease, this tends to flare in the first trimester and then postpartum, and it tends, if anything, to settle later in the pregnancy. So if you need to treat Graves' disease in early pregnancy, it's often reasonable to cease therapy at the end of the first trimester and then just monitor. As I'll highlight in a moment, the use of anti-thyroid medication in pregnancy is problematic and has become more problematic in recent years as we appreciate more about the toxicity of these drugs in pregnancy. But if you have to use anti-thyroid medication in early pregnancy in the first trimester, Propylthiouracil is the preferred agent, mainly because this is more tightly protein bound, less likely to cross the placenta. However, it is associated with a 1 in 5,000 risk of hepatic failure, so it's not a drug to be used lightly. In addition, it's been demonstrated to cause issues with embryopathy, with face and neck cysts, hydronephrosis, and genital abnormalities in the fetus. So that's problematic, but so too is carbimazole or neomercazole. It can cause the well-recognised side effect of aplasia cutis, or a defect in the scalp, which is pictured here, but also these other fetal abnormalities, which I've never seen in pregnancy, but they are described in the literature. So as you can see, the use of antithyroid medication in pregnancy is problematic. We would use Propylthiouracil in the first trimester and later in pregnancy if need be, which would be unusual. We would use carbimazole. The one situation where I've actually had to treat hypothyroidism in later pregnancy is in a couple of patients I've had over the years with nodular disease, where the hypothyroidism does not settle down as the pregnancy progresses. Hypothyroidism in pregnancy, and this is an area of great controversy in the medical literature, and we all know that magic cutoff of a TSH of less than 2.5 being an optimal TSH preconception and the first trimester of pregnancy. And I must say that the medical literature relating to this is actually quite poor, and recently there has been debate about whether a TSH of less than 4 millionits per litre is in fact more appropriate. But I think I personally stick to the 2.5 or less, because at the end of the day, the worst thing you're going to do to the patient is give them low-dose thyroxine, which really is not a big deal and doesn't carry with it any significant side effects. So if you've got a patient, a woman who's overtly hypothyroid, and you don't treat them, there's an increased prevalence of abortion, anemia, gestational hypertension, placental abruption, and postpartum hemorrhage in these women. And also in terms of the baby, it's associated with premature birth, low birth weight, and neonatal respiratory distress. And then there's this great debate and constant source of angst, especially when our patients go to Dr. Google, in terms of issues with the IQ of the child, of the mother who has untreated hypothyroidism being reduced, or neurological deficits. In all my years of practice, I've never seen this, but it is described in literature. But again, the literature is quite poor, and if there is a change in IQ of the child, then it's fairly marginal, probably in the order of about 6 IQ points, if anything. But I have never had it flagged with me as a clinical issue that my little Johnny's not doing so well at school. Could it be that I was hypothyroid when I was pregnant with him? But having said that, it's of course prudent to keep thyroid function in the optimal range through pregnancy. And on average, women require an extra 25 to 50 micrograms per day of thyroxine extra as the pregnancy progresses. And it depends on how deranged thyroid function is, but it's reasonable to check thyroid function at the onset of pregnancy, 4 weeks, 12 weeks, and around 26 to 28 weeks. In postpartum, it's important to revert to the pre-pregnancy dose of thyroxine and check thyroid function tests 4 to 6 weeks postpartum. This is an interesting topic. That is the topic of the euthyroid patient who has positive thyroid antibodies and their significance in early pregnancy. And there was a study published about 9 years ago that looked at about 8,000 pregnant women, and it suggested there was a 2 to 5 times increased risk of miscarriage and preterm birth in women who had positive thyroid autoantibodies. And there was another study predating that suggested a benefit of low-dose thyroxine in euthyroid women who had positive thyroid antibodies. And we've based a lot of our treatment protocols on this particular study over the last 14, 15 years. However, another larger, more powerful study was published last year, and it showed no benefit in treating women with positive thyroid antibodies with thyroxine who are euthyroid. However, my approach and the approach of a lot of others is that it is reasonable to treat women who have positive thyroid antibodies in the context of unexplained miscarriage, especially recurrent miscarriage, with low-dose thyroxine, say 50 micrograms per day for the first trimester or so. Postpartum thyroiditis is actually much more common than we realise. And I'm sure that you don't see in your practices, and I don't see in mine, 10% of postpartum women with postpartum thyroiditis. A lot of these women just suffer in silence. You know, they're a new mum with a baby and they feel ordinary, and they just think, I've got a new baby, and it's never diagnosed. But up to 10% of women in the postpartum phase may develop postpartum thyroiditis in the 2 to 10 months post-delivery. Risk factors are concurrent autoimmune disease, Graves' disease in remission, chronic viral hepatitis. It's generally a self-limiting transient condition, but sometimes requires a brief course of thyroxine if they're particularly symptomatic. And occasionally these women can go on to develop permanent hypothyroidism. They may initially have a brief thyrotoxic phase, which generally doesn't require treatment. They have high titers of TPO antibodies, and this often recurs after future pregnancies. And the particular scenario where you really should think about this is the woman who develops postnatal depression, 2 to 10 months postpartum, and it's always a good idea to check thyroid function because they may have undiagnosed thyroid disease in that situation. Okay, so that's pregnancy out of the way. What about thyroid antibodies? I get referrals for this, and basically there are 3 main antibodies that we check: antithyroglobulin antibodies, antimicrosomal or TPO antibodies, which are associated with both Hashimoto's thyroiditis and with Graves' disease. And then there's TSH receptor antibodies, which are specific to Graves' disease. And it's important to appreciate that Hashimoto's thyroiditis and Graves' disease are not 2 different diseases. They're different ends of the one autoimmune spectrum. So these antibodies are very, very common. They can be found in up to 15% of euthyroid adult females and 2% of euthyroid adult men. By themselves, they don't cause any particular symptoms. They do cause the histological appearance of thyroiditis. And they are a flag that the patient who has antibodies is at increased risk of developing abnormal thyroid function, more likely hypothyroidism. And there's no great role in following antibody levels. There are diagnostic tests. So once the patient has them, they always have the antibodies, and they tend to fluctuate, and in itself that means nothing. So it's a diagnostic test, and it does not particularly influence our treatment. What about sick euthyroid state? This is quite common, and if you have somebody who's particularly unwell, there's a significant chance that they will have sick euthyroid state. And basically, this is a response of the hypothalamic pituitary thyroid axis to severe acute intercurrent illness, and it's mediated by cytokines. And there's a few variants. One is where there's a low free T3, normal free T4, and TSH, and this is caused by reduced peripheral conversion of T4 to T3. There's a situation we often see in ICU patients where they've got low, that should read low free T3, free T4, and a normal TSH, and that's associated with a poor prognosis. The TSH can be anything. It can be low or it can be high, usually under 20 milliunits per litre. It's often seen in acute psychiatric illness, and these patients distinguish themselves by having often an elevated free T4 with normal T3, and the TSH which can fluctuate. Renal disease can be associated with a low free T3. And the diagnosis depends on the history, whether there's a personal or family history of thyroid disease, symptoms of thyroid disease, examination for goiter and signs of thyroid disease. And the treatment of this is simple observation. As the patient recovers from their acute illness, then you would expect the thyroid function to return to normal if indeed it is a sick euthyroid state. So primary hypothyroidism, it's easy when it's overt, when there's a low T4, T3 and high TSH. It's a bit more controversial, and the literature is still not conclusive about this when the patient has subclinical hypothyroidism. That's more significant if there's positive antibodies, because that means there's evidence of autoimmune thyroiditis. And what to do if the patient's symptomatic? Well, I think a lot of us would treat them. Certainly if their TSH is over 10 and they're quite symptomatic, it's reasonable to treat. It's got a small but significant 4% annual risk of progression to overt hypothyroidism. And in the elderly, it may be associated with an increased risk of death in the medium term. It's most commonly caused by autoimmune thyroiditis. It can be an end result of subacute thyroiditis. It can be a consequence of radiotherapy and obviously in the post-surgical situation. And primary hypothyroidism is common, especially in women, affecting about 1 in 30 women over the age of 40, and women develop hypothyroidism 10 times more commonly than men. And these are some of the symptoms which you'll be familiar with. Just a couple of things to flag that hypothyroidism is one of the reversible causes of delirium and dementia and should be thought of when a patient presents with issues with cognition, memory, concentration. It's also an important diagnosis to exclude in our patients with depression. And another interesting area, and I've seen a couple of cases of this over the years, is nerve entrapment syndromes like carpal tunnel syndrome. I've had a few patients who've developed carpal tunnel, and an astute GP has done thyroid function test and they've got hypothyroidism, and the carpal tunnel syndrome resolves when you treat the hypothyroidism. So that's an interesting presentation of hypothyroidism. The signs of hypothyroidism, these are the textbook signs, and I think it's fair to say in 2020 with wider screening for thyroid disease and more available and more accurate screening for thyroid disease, we don't often see the signs of thyroid disease that are in the textbook. In 30 years, I've seen one case of hypothermia due to hypothyroidism, and that was a woman who was in a myxedema coma, which fortunately I've only ever seen once. But a lot of these other symptoms don't tend to occur. The reflexes is something that, if you think somebody's hypothyroidism, the delayed upstroke of reflex is pathognomonic for that, and it disappears once you start giving the patient thyroxine. So I'd always encourage you, if you think somebody's hypothyroidism, tap the reflexes. Management, important to exclude other concurrent autoimmune endocrinopathies like pernicious anemia, Allison's disease. That's especially relevant if the patient has severe hypothyroidism, because in that situation, they may have concurrent Addison's disease, and if you treat the hypothyroidism, you might unmask the Addison's disease and trigger an Addisonian crisis. So it's always a good idea to check the 9-AM plasma cortisol and ACTH in somebody who is severely hypothyroid. Celiac disease, again, should be looked for. And if they require thyroxine and they've got no endogenous thyroid function, such as in a post-total thyroidectomy patient, the dose requirement there is 2 micrograms per kilogram per day. But we usually start, and it depends on the severity of abnormality and the age of the patient, somewhere between 50 and 150 micrograms of thyroxine per day. In an elderly patient or a patient who's got significant cardiac disease, we start with a low dose, say 25 micrograms per day, and gradually increase the dose. It's best to take thyroxine away from food, but it can be taken at any time of the day. And I'm always asked about diet. Are there things in my diet that can alter the absorption of thyroxine? Theoretically, yes. Things like soy products, things like broccoli, Brussels sprouts, cabbage, but I've never seen a dietary, a particular thing in the diet cause a problem with thyroid function abnormalities. The other thing that may cause an issue with thyroid function in somebody taking thyroxine is if all of a sudden they're given a large iodine load. That can destabilize thyroid function. You might remember the Wolff-Chaikoff effect from physiology days a long time ago. Well, basically, if you give a large iodine load, and the naturopaths sometimes do this, that can potentially cause a Wolff-Chaikoff effect and destabilize thyroid function. But otherwise, diet is really not a major issue in terms of thyroid function in somebody receiving thyroxine. And once started on thyroxine, it's important to titrate the dose every 4 to 6 weeks. And often when you're close to normal thyroid function, people often make the mistake of making larger changes in thyroxine dosage when only small fine-tuning doses are required. And often if somebody's close to euthyroid on their blood test, I might just tweak the thyroxine by 50 micrograms a week and this gradually chip away every 4 to 6 weeks until they're euthyroid. What about T3 therapy? This is something that is debated, and I've got patients who take T3 who are hypothyroid and they take it with benefit. It's something to be used very cautiously. especially in the elderly or people with cardiac disease. And I've actually seen a patient die from T3 therapy from heart failure, an older patient. So it's not, that was when I was a registrar a long time ago. So you've got to be a little bit careful. But if you've got a patient who is still symptomatic despite having T4 and TSH in the normal range, and their T3 is either in the lower limit of normal or low, persistently low, then it may be reasonable to cautiously give a little bit of T3 therapy. But be careful. What about thyrotoxicosis? I'm sure you're all more familiar with the biochemical diagnosis of thyrotoxicosis. Just to say that T3 toxicosis is more common in patients who have underlying nodular disease. Subclinical thyrotoxicosis is controversial, but we do know from the literature that it's associated with a 3 times increased risk of atrial fibrillation. It's associated with increased bone turnover. It's associated with increased risk of hip fracture in the very elderly, that is people over the age of 80. But we need to assess clinically. And if you've got somebody who's got a marginally suppressed TSH and they're perfectly well and no symptoms of hyperthyroidism, and especially in a younger patient who's under the age of 60 and at low risk of atrial fibrillation, it's reasonable to follow these patients and not treat them. But then there's the debate about older patients, whether you treat them. What are the causes of thyrotoxicosis? Over half is due to Graves' disease. Nodular thyroid disease, either single multinodular thyroid disease is an important cause. Thyroiditis, which can be caused by amiodarone, it can be caused by lithium and iodine, and for completeness I should say also from a viral infection, which is the classic subacute thyroiditis. Thyrotoxicosis factitia, which is a variant of Munchausen syndrome. I've never seen that, but it is described in literature. And then secondary thyrotoxicosis, which can be caused by a pituitary tumour or thyroid hormone resistance. And these patients have a elevated or non-suppressed TSH in the context of high free T4 and or free T3. And then struma overa, which is where there are thyroid rests in the ovaries, is a very rare cause of thyrotoxicosis that I've never seen. It's not as common as hypothyroidism. And these are some of the symptoms that I'm sure you're all familiar with. Just to highlight that pruritus is an interesting presentation of thyrotoxicosis, and I can think of 3 patients who went to dermatologists and liver specialists before they came to an endocrinologist who had pruritus caused by thyrotoxicosis that resolved with treatment. So that's an interesting one to bear in mind. And of course, subacute thyroiditis is associated with thyroid tenderness in many cases, although not always. What are the signs? Resting tachycardia, arrhythmia, significant hypertension, increased pulse pressure, proximal muscle weakness, which can be quite profound, especially in an Asian population, goiter, which may be tender in subacute thyroiditis. There may be a thrill or a bruit if the patient has underlying Graves' disease, and if you feel a thrill or listen to a bruit over the thyroid, that's pathognomonic of Graves' disease, and you've made the diagnosis. And then, of course, there are the signs of thyroid eye disease, which point towards Graves' disease being the underlying cause. What is the management outside of pregnancy? Thyroid nuclear scan, which will ascertain the etiology of the hyperthyroidism. TSH receptor antibodies are helpful because if they're elevated, that may signify underlying Graves' disease. But I now do TSH receptor antibodies in any patient who I'm planning to give radioactive iodine to, even if the nuclear medicine scan suggests that they've got nodular disease. I've had a couple of patients over the years who have certainly had nodular disease on nuclear scan, but they've developed thyroid eye disease after having radioactive iodine, and you do their TSH receptor antibodies and they're positive. So it's possible to have both autoimmune thyroiditis and positive TSH receptor antibodies and nodular disease. And in that situation, if the antibodies are quite elevated or significantly elevated, I would be inclined now, based on experience, to steer away from radioactive iodine because that has an increased chance of causing a flare of thyroid eye disease. Antithyroid medication that we talked about with pregnancy, in Graves' disease, 12 to 18 months of therapy with antithyroid medication, which overall confers an approximately 50% chance of long-term remission. The caveats are that some patients just don't respond, and in that situation, you've got to go to definitive therapy early. If the patient has strongly positive TSH receptor antibodies, that reduces the risk of the chance of a remission, and I may be inclined to prolong therapy in that situation. If they've got nodular disease, at some point, once euthyroid, they'll need definitive therapy with either radioactive iodine or surgery, because the underlying cause of the thyrotoxicosis will not go away with a simple course of antithyroid medication. Subacute thyroiditis is generally self-limiting, although I've had a few patients who've had it several times, one patient 3 times, which is extremely rare, and these patients usually settle with a brief course of antithyroid medication, plus or minus prednisone. Theoretically, Propylthiouracil is preferred in the setting of subacute thyroiditis because these patients have a leakage thyroiditis, and PTU, as opposed to carbimazole, does have a role in reducing the peripheral conversion of T4 to T3. And these are some nuclear scans just to show you, and this is the typical appearance of Graves' disease with the diffuse goiter on nuclear scan with uniform increased uptake through both lobes of the thyroid. By contrast, this is a solitary nodule in the right lobe of the thyroid causing thyrotoxicosis. This is a multinodular goiter where there are several thyroid nodules which are hyperfunctioning, and perhaps a hypofunctioning nodule here and maybe up at the top of the left lobe. So that's your classic multinodular goiter. And this is thyroiditis of any cause with reduced uptake, and you can see there's a marker in the sternal notch, and there's uptake in the salivary glands, but there's no uptake at all over the thyroid gland. So these are the typical nuclear scan appearances in different etiologies of thyrotoxicosis. We've talked a bit about the antithyroid medications in the context of pregnancy, and the doses that we give are dependent on the severity of thyrotoxicosis, and between 5 and 30 milligrams a day of Neomercazole, but in severe cases, we can give a lot more than that. I recently had a young woman who had refractory severe thyrotoxicosis who, up until surgery, required 21 Neomercazole tablets a day to control her thyrotoxicosis, and she also required huge doses of beta blockers, and I gave her some dexamethasone to reduce the peripheral conversion of T4 to T3, and she sailed through a thyroidectomy last week accordingly. The dose is tapered over time to the minimum dose required according to thyroid function tests performed regularly, say every 6 weeks or so, give or take. And the side effects of these, and there's a couple that you may not be aware of, hepatotoxicity, especially with PT we talked about. I've had a couple of cases over the years of people developing an ANCA-positive vasculitis, and the dread side effect that we all talk about, but is actually quite rare in the order of 1 in 10,000, is leukopenia. That's usually with higher doses of antithyroid medication, but it's always prudent to warn the patient if they get a fever or sore throat that they should be, their white cell count should be checked to exclude leukopenia. What about radioactive iodine? We've been using it for a long time, and the indications for using this are nodular disease in some cases and recurrent and or refractory Graves' disease. At the dose we give for thyrotoxicosis, the patient does not require hospital admission. The usual radiation precautions are to be followed, and the patient should avoid pregnancy for 6 months after, although there is literature about women falling pregnant within 6 months, and I've had 2 patients over the years who've inadvertently fallen pregnant shortly after radioactive iodine, and there were no problems. Side effects: there's a 30% chance of hypothyroidism, there's a 5% chance of requiring a second dose. There may be some transient nausea and tenderness over the thyroid bed and salivary glands, and this is the important but fortunately rare group where there's exacerbation of thyroid eye disease, and use radioactive iodine with caution if there's pre-existing thyroid eye disease, patient's a smoker, and if they've got significant titers of TSH receptor antibodies. Thyroidectomy is used in some cases of nodular thyroid disease, Graves' disease. It's best to use an experienced thyroid surgeon because the more experienced the surgeon, the more cases of thyroidectomy that they do, the less risk of complications. And I'm sure that you're aware of these complications, which I won't dwell on. Other indications for thyroidectomy: compressive symptoms such as discomfort over the thyroid bed, dysphagia for solids at the level of the thyroid, issues with breathing, possibly due to tracheal stenosis, retrosternal extension, tracheal stenosis, and if there's a possibility of malignancy, are other indications for thyroidectomy. Subacute thyroiditis, we've sort of talked about, so I won't dwell on that, except to say that the hypothyroid phase that they sometimes get, generally transient, but occasionally can be permanent. And it's often caused by Coxsackie and Epstein-Barr viruses. It'll be interesting to see if COVID-19 gets implicated in causing this, as it has with a couple of other diseases in the last week or two. Amiodarone thyroid disease, interestingly, I think is rarer these days, whether the cardiologists are not using amiodarone quite as much. But amiodarone is 38% iodine, therefore it's taken up fairly avidly by the thyroid. It can cause hypothyroidism, which is not a big deal because you can just bypass what the amiodarone is doing and give the patient thyroxine. It's more significant when it causes hyperthyroidism, and there's two mechanisms here. It's either the iodine load, which is what we call the John-Bastow effect, which causes usually mild thyrotoxicosis, or it can cause an inflammatory thyroiditis, which is a more severe variant, and this is associated with marked cytokine release in the form of interleukin-6. And this is a very difficult condition to treat in some cases, especially as these patients are often elderly, they're in atrial fibrillation, they've often got issues with impaired cardiac function, and they often require high-dose steroids as well as Propylthiouracil to treat, and of course you would stop the amiodarone. In a couple of situations I've had to refer people over the years for emergency thyroidectomy, which is a procedure not without risk in this often elderly population. What about thyroid nodules? This is a common thing, and 6% of patients on physical exam in one clinical trial had a thyroid nodule that was palpable. If you look at ultrasound studies just screening people for thyroid nodules, anywhere up to 70% of the healthy population have a thyroid nodule. And interestingly, because of increased screening, and there's a prototype study out of South Korea showing this, in South Korea, women are actually offered a thyroid ultrasound at the same time as they have a pap smear and mammogram. And thyroid cancer, therefore, in Korea, the prevalence of this is taken off exponentially. And this is largely due to better screening. And it's interesting because a lot of these patients would have had thyroid cancer and never known about it, because we now know that a lot of early thyroid cancer spontaneously involutes and goes away without the patient ever knowing about it. And if you look at post-mortem studies, up to 2% of individuals who die for another reason at post-mortem have incidental microthyroid carcinoma. And we certainly don't see 2% of the population develop thyroid cancer. So there's a lot of evidence that thyroid cancers do tend to spontaneously involute, and we are picking up more thyroid cancer because of more widespread screening. But what is the risk of a thyroid nodule being malignant? Approximately 5% of thyroid nodules on ultrasound will prove to be malignant. Interestingly, whilst nodular disease is more common in women, thyroid malignancy in a thyroid nodule is double as common in men. And there are two peaks in thyroid cancer risk in patients under the age of 20 and in patients over the age of 70. And despite the teaching when I was a medical student, the risk of thyroid cancer is actually equal in a patient with a solitary thyroid nodule versus patients who have multiple thyroid nodules or a multinodular goiter. So what's the pathway for investigating and managing the thyroid nodule? The first thing is to look at the thyroid ultrasound, check the TSH, and if the TSH is suppressed, that should read the nodule may well be functional, it might be hyperfunctioning, and it's reasonable to obtain a thyroid scan. If the thyroid scan demonstrates an increased uptake consistent with a hyperfunctioning thyroid nodule, then measure free T3, free T4, and then you treat for hyperthyroidism according to the patient's symptoms and the biochemical abnormality. If the thyroid scan demonstrates the nodule is non-functional, or if the TSH is normal or high, the nodule is non-functional. In that situation also, then thyroid nuclear scan is not indicated, and you would either biopsy or observe based on the characteristics of ultrasound. Okay, you would have seen on some of the ultrasound reports from some, but unfortunately not all radiologists, that the radiologists now are increasingly categorizing the thyroid nodule in terms of this system of T-rads, which came from the American Thyroid Society, and they talked about this in great detail at Harvard a month ago when I did the online course. So now we don't just look at whether the nodules are solid or cystic, we look at all these different factors, the the composition of the thyroid nodule, echogenicity, the shape of the thyroid nodule, margins, and echogenic foci. And we score the nodules according to each of these characteristics. So, for example, if the nodule is almost completely cystic, then it scores 0 for composition. If it's solid, it scores 2. If the nodule is hypoechoic, which means that it's darker than surrounding thyroid tissue, then we score it higher than if it's got the same echogenicity as surrounding thyroid tissue. If the nodule is wider than it is tall, then it scores 0 on shape. If it's taller than it is wide, then we would score it with 3. We look at the margins, and if they're ill-defined, lobulated or irregular, or there's extrathyroidal extension, that scores higher than if the margin of the nodule is smooth. And we look at things like echogenic foci, whether there's calcifications in the thyroid. And then we add those different features up, and that gives us a TRAD score. And that goes between T1 and T5. So TR1, the chance of it being malignant is very low, and biopsy in this situation is not indicated, nor is it indicated in TR2 where it's low, and you would simply follow the patient with a progress ultrasound probably in 6 to 12 months. It gets interesting when you get to TR3 and above because the chance of malignancy does start to increase in patients who have TR3, TR4 and TR5. And you can see in TR5 there's a very high chance of malignancy, as high as 35%. And in that situation, there's a lower threshold for biopsying even the smaller nodules down to about 10 millimeters. So this is quite helpful, this classification, but unfortunately, a lot of our radiologists are still not doing this. And I'd encourage you, if you do thyroid ultrasounds, to find a radiologist who does this and stick with them, because it is very helpful. And the aim of this is to fine needle biopsy people who really need the fine needle biopsy. If you're TR1 or TR2, you don't, in the first instance, need a fine needle biopsy, but you certainly do if you start getting towards TR3 and above. And these are just a couple of examples of, this is a nodule that's taller than it is wide, and that would be TR3. This is a hypoechoic nodule. You can see this is actually darker than surrounding thyroid tissue. And here's some nice examples of microcalcifications. So these are just examples of the different ultrasound features that help us better characterize thyroid nodules. And this is a messy slide, and I'll simplify it by saying there are basically 4 diagnostic categories. And when you're looking at fine needle cytology, it is just that, it is cytology, it's not histology. And that's one of the limitations of fine needle biopsy of a thyroid nodule. You are only getting information about cytology. You're not getting information about histology, which is giving you information about the architecture of the thyroid nodule. That is, how do the cells relate to each other? Is there invasion through the capsule? All those sorts of things. Is there invasion into blood vessels or lymphatics, etc., etc. So there are 4 categories of results for fine needle biopsy. Non-diagnostic, which is a problem, often when the radiologist hits blood, and in that situation you've got to repeat the biopsy a couple of months later to let any hematoma in the nodule resolve. Benign, which is a reassuring cytological diagnosis, and you then follow them with progress ultrasound. Malignancy, where the patient is referred for thyroidectomy and other treatment. And then there's this problem area in the middle, the so-called atypical thyroid nodule, where the cytologist can't distinguish between benign and malignant. In the old days, we used to just send these people off for thyroidectomy to get the histology. In most cases, we would, in 2020, simply repeat the fine needle biopsy in a few months. And if after repeat biopsy there's ongoing questions about whether it's atypical, benign or malignant, we then consider the surgical option of excision of the nodule at the very least. So that's the end of the thyroid part of the talk. I hope I've overwhelmed you with thyroid, but if there's any questions, I'm happy to take them related to thyroid at this point.
Steve, can you hear me at the moment? It's Anna.
Oh, yes, Anna, I can hear you.
Oh, hello, everyone. I don't know what was happening before, but I wasn't able to introduce Steve at the start. I've got a few questions. We've probably got about 10 questions so far from the first section. So actually, I can even turn my video on. Hello. So the first question we've got is, how can you tell the difference between lymphocytic thyroiditis and Hashimoto's?
That's a good question. In fact, they're pretty much one and the same. They're just different names for the same condition, because the underlying histology of Hashimoto's thyroiditis is a lymphocytic thyroiditis. So I guess it's a more histological diagnosis as opposed to a clinical diagnosis, but you're referring to one and the same thing.
Now, the next question here is, do we need to monitor the white cell count in patients on Neomercazole?
The answer is yes. I tend to do it every time I check thyroid function, but the problem is that the leukopenia that you develop is idiosyncratic. So you can have a normal white cell count when you see the patient 1 week, and a week later they can develop a leukopenia. So it's important to warn them about the symptoms of fever and sore throat, and if they get those, they'd probably think of COVID-19 right at the moment, but if they're on Neomercazole or PTU, then they should also think about white cell count.
And we've got, would you suggest that we check the thyroid function, the TSH, in all women who are planning to conceive and treat with thyroxine if the TSH is less than 2.5, or only if they're having trouble conceiving?
That is a subject of great debate, and I don't think there is a consensus amongst endocrinologists and obstetricians about this. I personally think, it's a very simple test to check the TSH in all women planning pregnancy or who are newly pregnant, and the evidence, as I said before, about that magic TSH of 2.5 is somewhat skewed, and there's debate about whether the cutoff should be in fact less than 4 milliliters per litre. But if the TSH is over 2.5, there's no great harm in giving the woman thyroxine, at least prior to conception, and then for the first trimester when fetal neurological development is important.
I think we still have debates with the hospital about whether to even do a TSH on their initial pregnancy bloods. I do it, but I'm not convinced it's still in the protocol.
I don't think it is, actually.
No. Now, next question. Patients on amiodarone, should we be doing a TSH or full TFTs?
I think a TSH by itself initially is reasonable, and if it's abnormal, that's when you would add in the T4, T3. But if they're symptomatic, if they're unwell, I think just do everything straight away, especially if they've got symptoms of hyperthyroidism. Although these patients often don't get the full gamut of symptoms of hyperthyroidism. They may present just with arrhythmia, they may present with unexplained new heart failure, or just non-specific extreme lethargy. So they're not like the young patient with Graves' disease who comes to your office with tremor and sweating and the full gamut of signs. These patients often don't have a lot of symptoms or signs.
Now, Bertha's just sent me a few more different questions, so just give me a second until I've had a read of those. If the person has low urinary iodine, what would you ask them to buy? If they're using iodized salt, besides Blackmores with folate, ifolate, what else would you suggest for them?
I think probably just a liberal dose of iodized salt would be as reasonable as anything, and then follow that up with progress urinary iodine, aiming for a normal range. I was going to talk about iodine pregnancy, but I had too much material, so I left it out, unfortunately.
Now, someone else has said they're talking about the T1 RAD classification. It doesn't mention a size of nodule. How does the size of the nodule fit into how we assess the nodules? That's a really good question. Thanks for that one, Wayne.
That's a really good question. And the answer is that T1 nodules are generally, in just about all cases, just a simple cyst. And at the end of the day, a cyst is just a hollow space full of fluid and there's no cells. So, I think in that situation, there's no threshold or no size of the nodule that indicates the need for a fine needle biopsy, and you'll just simply watch it over time, because at the end of the day, if you stick a needle in, you're just going to get colloid back and not get any cells, and it's not going to change what you do. The one situation where you would biopsy a T1 nodule that's a simple cyst is where the patient is symptomatic. And I've had a few patients over the years who've had an enormous simple cyst, and you stick a needle in, drain off 30, 40 mils of colloid, and their compressive symptoms go away, although it can then reoccur.
So I think in the interest of time, we probably should get on to the next section. If anyone else has any additional questions, please keep sending them through to Bertha, and then she'll send them over to me. So Steve, you ready to keep going?
Absolutely. So I'll move on to osteoporosis. This is a picture of the Taj Mahal taken Christmas the year before last. And I wish I was there now, because apparently the skies in India are clear as clear. And it wouldn't be all smoggy like it was here. So COVID-19's had that, I guess, beneficial side effect to the environment in northern India. So we'll move on to osteoporosis, and I'll try and belt through this so that there's some time for questions at the end. Just to highlight, and you all know this, but it has implications for screening, and none of us, me included, are that good at screening for osteoporosis. It's very, very common, and in 2001 affected 2 million Australians. And I have a personal interest in this because I actually fractured my right neck of femur last year, which is a rare injury for somebody my age. So having been through that, I haven't got osteoporosis, but I appreciate the end point of it. It's not very nice. So we need to be more diligent with screening our, especially elderly patients, for osteoporosis. What are the risk factors? And these I'm sure you're familiar with. Just to flag and highlight positive family history, that's extremely important. And if you look at risk calculators for osteoporosis, the FRAX one that I use in my practice factors this in significantly. Immobility of any cause is important, and pretty much any chronic disease state, especially if it's inflammatory, can increase the risk of getting osteoporosis. And this is a list of diseases associated with osteoporosis, most of which you'll be familiar with. Just a couple to highlight: liver disease, malabsorption, and that can be after gastric surgery or bariatric surgery. And that's an important group to follow with bone density, as the patients who've had bariatric surgery, chronic airflow limitation, premature menopause, eating disorders, and diabetes mellitus. There is some data that both type 1 and type 2 diabetes mellitus can be associated with reduced bone density. And then, that has implications for how we use the fracture risk calculator, which I'll get to later. These are some drugs that can cause osteoporosis, which includes warfarin, lithium, anticonvulsants. These you'd be probably familiar with. Vitamin D deficiency is very common, and the reason I fractured my neck of femur is that I was profoundly vitamin D deficient, which surprised me because I don't drive and I walk everywhere on the weekends, and I thought I got enough sunshine, but I'm now on 5,000 units of vitamin D a day and barely maintaining a D level over 75. So between 30 and 60% of patients in Australian studies have vitamin D deficiency. Part of this is cultural, and especially women who cover up for cultural or religious reasons, but also because we tell people to get out of the sun because of skin cancer. And these are some of the consequences of even subclinical vitamin D deficiency: osteoporosis and osteomalacia, obviously. Musculoskeletal pain and muscle weakness is important. And I've had a couple of patients who presented like they had polymargia rheumatica. They were vitamin D deficient. You fix that and their muscle aches get better. And falls and fractures are also endpoints of untreated vitamin D deficiency. Diet's a minor source of vitamin D. You can get a little bit from diet, but most of it we get from sunshine. And then, of course, there's the role of supplementation. And this was a meta-analysis published in 2005 in the New England Journal, and it looked at numerous studies, pulled the data together, and they showed that if you achieve a D level of over 100 nanomoles per litre, which is probably higher than most of us would aim for, that led to a 26% reduction in hip fracture. So that's interesting. What about calcium? We all know about calcium supplementation in older patients. There's a lot of controversy as to whether this leads to cardiac issues, but I think it's fair to say that as of now, the literature is very much divided on this, and there are studies showing that it can cause cardiac issues. There are other studies showing no increased risk of cardiac issues. I guess if somebody's got, significant cardiac disease, it's prudent to be a bit circumspect about calcium and probably aim to give the patient their calcium from dietary sources. These are the common osteoporotic fracture sites, and I'm sure you're familiar with all of these. I'm sure that you're aware of the morbidity and mortality of hip fracture. Up to 33% of patients can die within 12 months of a hip fracture, and this is largely in the average hip fracture patient who is in their late 70s, early 80s. Of those who survive at 12 months, 40% are not able to walk independently, and they may have problems with at least one essential activity of daily living, and it's the most common cause of disabling injury or accidental death in the elderly. And I apologise for this slide because part of it goes off the bottom and I couldn't rescue it. So every day more than 40 Australians break their hips, 2 will die in hospital, 4 will go to aged care, less than 20 will walk as they did prior to the fracture, and after 12 months, 6 to 7 of them will have died of complications related to the hip fracture, not the hip fracture itself, things like thromboembolic disease, pneumonia, pressure ulcers, etc. What about vertebral fractures? We know that these cause pain and misery, but there is quite a lot of evidence that vertebral compression fractures in themselves are associated with excess mortality compared to age-matched women who have not had a vertebral fracture. So I think that's important to bear in mind as well, especially in the elderly patient who's had multiple vertebral fractures. If a patient has had a previous fracture, by definition, that patient has osteoporosis irrespective of what their bone density is. So if a patient has had an atraumatic vertebral fracture or a fracture at hip or one of the other sites of osteoporotic fracture, this increases the likelihood of additional vertebral fractures by at least 4-fold, and therefore, in my opinion, and I think there's consensus about this, that these patients should be offered specific osteoporotic treatment over and above the usual things we do to treat patients with osteopenia, which I'll cover separately later on. These are the standard pathology tests you would do in screening somebody who's got reduced bone density: renal function, calcium phosphate looking for hyperparathyroidism, liver function tests, TSH looking for hyperthyroidism, ESR, which is a crude screen for myeloma, 25-hydroxyvitamin D, and celiac serology. Now, the normal range for 25-hydroxyvitamin D depends on the assay, but usually over about 50-51 nanomoles per litre. If somebody's got reduced bone density, you need to ideally keep the D level to greater than 75 nanomoles per litre, because there's some evidence that switches off increased parathyroid hormone production and increased bone turnover. These are extra investigations that may be required depending on the situation. What about the management? Lifestyle is critically important. So optimal calcium intake, exercise, and there's some evidence that weight-bearing exercise or resistance exercise may be useful. It may have a direct effect, a direct modest effect on improving bone density, but also, of course, it also improves muscle function and muscle strength. Lifestyle factors, especially relevant in men: stop smoking, limit alcohol to less than 4 standard drinks a day in men and less than 2 in women, optimize vitamin D status, and as I said before, if there is a fracture due to minimal trauma, then patients with osteopenia should be treated for osteoporosis. What about routine use of osteoporotic medications in osteopenia? There is one study from Ian Reid in Auckland, which was published in the New England Journal in 2018, looked at 2,000 women either given zoledronic acid or a cluster or placebo for 6 years. And after 6 years, the women who received active treatment with zoledronic acid certainly had a significant reduction in first fragility fracture and non-vertebral fragility fractures. However, the number needed to treat was quite large, and therefore, I guess, risk-benefit of using zoledronic acid in this population with early loss of bone density and osteopenia is in 2020 questionable. And of course, there are economic issues associated with using that particular drug widely. And finally, to say that this group of patients with osteopenia are not PBS reimbursed for using osteoporotic therapy in simple osteopenia, not complicated by fracture. So it all comes back to lifestyle, avoiding toxins like alcohol and cigarettes, and I should say any medications that may increase the risk of bone loss, minimise the exposure to those, and get the vitamin D status right. Treating osteoporosis, I think it's important just to highlight that no patient is too old for treatment, and elderly patients especially, number needed to treat to reduce further fractures is actually going to be fairly low in a very elderly patient. So, you know, there's a higher benefit in those patients than somebody who is, say, 60 who has a solitary fracture. And these are some increased independent predictors of fracture: bone density, of course, bone turnover, previous fracture, especially vertebral, family history, corticosteroids, and falls risk. So, testing and diagnosis of osteoporosis. If they've got overt osteoporosis, treat to prevent first fracture, guided by the PVS, of course, and follow bone density. Osteopaenia we've talked about. Lifestyle, vitamin D. Falls prevention is important, and we'll touch on that in a minute, and then follow bone density over time. So this is the FRAX risk calculator, which some of you may have seen. It was devised by Jack Canis at the University of Sheffield, and there are actually databases for most countries in the world, including Australia. So when you use this calculator in Australia, the answer you get is based on a local database. And you can see that we look at the patient's age, we look at their gender, their weight, their height, previous fractures, genetic factors. Has a parent had a fractured hip? Smoking, glucocorticoids, rheumatoid arthritis, secondary causes of osteoporosis, more than 3 standard drinks a day, and we look at the bone density at the femoral neck. And there you can either type in the actual bone density, but you have to actually look at the particular machine that the bone density was measured on. It's actually simpler to simply elect to type in the T-score and type that in. And then once you've typed that in, you push calculate, and then you're given a 10-year probability of a fracture of either a major osteoporotic fracture anywhere in the body or of a hip fracture. And this is quite helpful in stratifying those patients we should treat versus those that we don't. And it's also quite helpful in convincing patients about the need to treat osteoporosis, because they come in with this stuff from Dr. Google looking at osteonecrosis of the jaw. But this is the counter argument to that. You've got to weigh up the risk of that versus the risk of fracture if we don't do anything. There are some limitations in using FRAX, and interestingly, there's some recent evidence that it may underestimate the risk of fractures in patients with diabetes. And the suggestion is that if the patient does have diabetes, that you tick yes for the rheumatoid arthritis box, because the risk of fractures with diabetes seems to be similar to that in patients who've got rheumatoid arthritis. If the patient has a major problem with lumbar spine bone density, that is, their hip bone density is not too bad, but the lumbar spine bone density is a problem, then FRAX may underestimate the risk of fractures, especially vertebral fractures. It doesn't factor in the risk of falls, it doesn't factor in recent fracture, and it doesn't factor in a parental history of non-hip fracture. All of these last 3 entities increase the risk of fracture. So it's not a perfect risk calculator, but it's better than nothing. Finally, it doesn't give us a dose-response relationship to things like use of steroids over time, smoking exposure, how many pack years of smoking, or the number of previous fractures. So if you've had 1 fracture, the yes box is ticked, and it's ticked in the same way if you have 10 fractures. So there are some limitations, but look, it gives us a rough guide. We have a local risk calculator, which is the Garvan Fracture risk calculator, which is a little bit simpler to fill out, and it does factor in falls. But in my experience, if anything, it probably overestimates especially hip fractures, and there's often a wide disparity between the FRAX risk calculator and the Garvan risk calculator. So I think around the world, the FRAX one is used more widely, but as you can see, they both got their limitations. And what are the thresholds for treatment? This has not been conclusively studied and demonstrated, but I think it's reasonable to treat if there's a greater than 3% 10-year risk of a fracture at the hip and a greater than 20% risk of a fracture of major osteoporotic fracture at any site that people can develop osteoporotic fractures. These are the options of therapy in 2020, and you'll be familiar with all of these. And I'm going to focus briefly on the bisphosphonates and a little bit about denosumab or Prolia, and a little bit about teriparatide or thyroid hormone, parathyroid hormone This is unique in that this actually has an action in increasing bone formation, whereas the rest of the drugs pretty much work by reducing bone resorption. So I won't dwell on this slide except to say that I don't use the oral bisphosphonates very much in 2020. I think we've got better drugs. And in particular, whilst they're efficacious in terms of reducing fracture risk, they're associated with significant risk of side effects. They're fiddly to take, which leads to compliance issues, and I therefore don't use them very much these days. Zoledronic acid, I still use. In my experience, the side effects of this are more severe than the side effects that patients experience with denosumab. But just a couple of things to mention. It's contraindicated if EGFR is less than 35. There certainly are some issues with uveitis and scleritis, rare side effect, but I've seen it once in a patient receiving zoledronic acid. But interestingly, and we do tend to forget this because it's old data, that in a hip fracture trial that was published in New England Journal in 2007, zoledronic acid actually reduced fractures as you'd expect, but interestingly also reduced all-cause mortality for reasons that are not fully explained. So there may be a survival benefit in patients receiving zoledronic acid. Just an interesting observation. Just talking about osteonecrosis of the jaw. I won't dwell on this again because you're all familiar with a lot of this stuff. It's mainly in intravenous bisphosphonates, and it's usually in patients receiving a very high dose of bisphosphonate or denosumab in the context of cancer, or if they're on high-dose oral glucocorticoid therapy. And in the cancer group, the risk of ONJ can be as high as 10%. The risk of ONJ in patients on bisphosphonate is about 1 in 10,000. With denosumab, it's about 1 in 50,000. Risk factors include, obviously, invasive recent dental work, trauma to the jaw, infection, and I'm sure you're familiar with how it presents. It's prudent to check dental health prior to commencement of osteoporotic therapy. That should also apply for denosumab. And there is value in withholding denosumab prior to dental work because, as I'll talk about in a moment, it's pretty much out of your system after 6 months. So theoretically, at least, the risk of ONJ if you withhold or if you wait 6 months after the last Prolia injection is less. Now, there's a magic 5-year rule for bisphosphonates and osteoporosis. This comes from a FIT study, which looked at patients taking alendronate for 5 years versus those who took it for 10. And those who stopped it after 5, there was a fall in bone density, but it did not go back to baseline. So that's where this magic 5-year rule came from. And I think after 5 years, it's reasonable to withhold bisphosphonate therapy if the T-score is reasonable, if there's been a good DEXA response, not ongoing problems with fractures, but people, of course, do need to be monitored with bone turnover and/or markers of bone density and/or markers of bone turnover. The other reason for not giving bisphosphonates indefinitely is this theoretical and rare consideration of frozen bone syndrome. And this is the classic mid-femur fractures or atypical fractures, which is also quite rare. And we do also see this in patients on denosumab or Prolia. So with the bisphosphonates, this is another reason to stop therapy and give the patient a drug holiday after, say, 5 years, but then follow them carefully and retreat if bone density declines, and certainly if they, experience more fractures. Denosumab, I won't dwell on the mode of action. I'm sure that you've been to talks about this over the years. Just to highlight that the effects are reversible on discontinuation of treatment, and that's why theoretically the risk of ONJ with invasive dental work is probably less after 6 months after the last injection. And this is how it works. It inhibits rank ligand, which basically nobbles the osteoclast so that it doesn't work properly and reduces bone resorption. So it's been demonstrated in quite a few clinical trials to reduce the risk of fractures, both hip, vertebral and non-vertebral, generally quite well tolerated. There's a rare risk of cellulitis or respiratory infection, and there's a 1 in 50,000 chance of ONJ, as I said before, and of atypical femoral fractures. But generally speaking, this drug is very well tolerated. Just to highlight that bone density does rapidly decrease after the discontinuation of denosumab, and in the FREEDOM trial, an increased risk of multiple vertebral fractures was demonstrated when patients ceased denosumab. So in that situation, it's prudent to offer alternative anti-resorptive therapy post cessation of denosumab, just to reduce the risk of bone loss and a cascade of new fractures occurring. What about teriparatide or Forteo? This is recombinant parathyroid hormone, and it's interesting because too much parathyroid hormone is bad for you. It increases bone loss and bone turnover, but a little bit is good for you, and it's anabolic, leading to increased bone formation. It's given as a daily subcutaneous injection, and in Australia on the PBS, it's indicated as a once per lifetime 18-month course. And it's indicated for those with severe osteoporosis who basically continue to fracture despite at least 12 months therapy on a first-line osteoporotic therapy. Very well tolerated. The injection itself is not a big deal. It's not dissimilar to giving yourself insulin. And the major side effect would be nausea and flushing, but even though those are quite rare. Excuse me. These are the PBS indications. It needs to be initiated by a specialist. It can be prescribed as a repeat prescription 6 months down the track by a GP. Patient has to be at high risk of fracture, bone density with T-score of less than -3. Patient must have had 2 or more fractures due to minimal trauma and at least 1 symptomatic new fracture after at least 12 months therapy with a standard anti-resorptive agent. Now, what about the patient who has, recurrent severe fractures due to minimal trauma, but their bone density is not too bad? You do a DEXA, a normal bone density, and their bone density is -2.4. They've got bad severe osteopenia, but not quite osteoporosis. Yet they keep fracturing. In that situation, it's one indication to think about doing a CT bone density, because this patient may have a problem where lumbar spine bone density is artifactually increased. It looks better than it really is because of the presence of degenerative change in the spine or calcification in the aorta. When you do the CT bone density, it gets rid of the artifact with degenerative change in the spine, etc., and you get, in that situation, a more accurate reflection of the true lumbar spine bone densities. That's a way of getting around bone density, and you may be able to qualify your patient for Forteo in that situation. Just to finish off, falls prevention. This is absolutely critical, and I know in my practice I'm guilty of overlooking this, but it's absolutely critical, because if I pump the patient full of drugs, but we do nothing about falls prevention, we've only done less than half of the job. So it's important to preserve muscle strength, muscle bulk, and in doing that, exercise and optimal vitamin D status are very important. And we call it sarcopenia, or loss of muscle in elderly patients, is an important risk factor for fracture. And it may be in the future that therapies will evolve to treat directly sarcopenia, not just reduced bone density. Reduced tendencies to falls, medication reviews, looking at meds that can predispose to falls, optimize the home environment. All these things are very obvious. And of course, the use of falls prevention clinics. It's more in the realms of the aged care physicians, but I think it behoves us to think about falls prevention in all of our patients. And just to finish, male osteoporosis, I was asked to talk about, and this is an important group. If you look at the Dubbo osteoporosis study out of the Garvan Institute, at age 60, 60% of women had osteoporosis. This is a screening of the entire town of Dubbo, but 30% of men had osteoporosis, so it's still a very common disease in men. And 30% of all hip fractures occur in men. If you look for underlying secondary causes, much more likely to find one in men than in women. And in particular, smoking and alcohol are important causes of osteoporosis in men, especially elderly men. If you look at therapies, testosterone therapy in a hypogonadal man by himself or by itself is not enough to treat osteoporosis. If they've got significant osteoporosis, you need to use the same drugs that you'll use to treat osteoporosis in women: bisphosphonates, denosumab, and teriparatide. And interestingly, in men who have hip fractures, and I published with Terry Diamond on this 30 years ago, the outcome of a hip fracture in an elderly male with osteoporosis is worse than it is in a woman of the same age. And the reason for that is that men who are quite elderly, in their late 70s, early 80s, tend to be frailer and have more comorbidities than a woman of the same age. So that's an important group. We need to think about osteoporosis in men as well as in women. So that's my last slide. I'll finish there, and I've left about 15 minutes for some questions. So thank you for listening to me.
Hopefully you should be able to hear me. I'll give you a few seconds to recover from that hour long of talking. There's quite a few questions, so I'll try and condense a few of them together. The first one is, what's your opinion on injectable depot vitamin D?
That's a good question. I use it. It's only available in Australia, made by a compounding chemist, and you need to be happy with your compounding chemist if you do that, because otherwise there can be issues with the patient getting the right dose. But I use it quite widely. It's a little bit controversial. There was a study out of Geelong probably about 12 years ago that suggested that giving a patient injectable vitamin D actually increased the risk of fractures, which sounds very counterintuitive. And I actually had a chat with the author of that paper over 10 years ago, and I said, well, it's counterintuitive. How does that make sense? And he said the only explanation we could come up with was that the people we gave the vitamin D injection to, it had such a profound effect on muscle strength and reducing muscle weakness that these people became more mobile and fell over. It all seems a bit counterintuitive to me. Vitamin D is vitamin D, and it certainly is more convenient to get an annual injection. And it probably works out to be cost effective too. I mean, depends on the compounding chemist, but it costs about $50 for an injection every 12 months as opposed to oral vitamin D. So yes, I use it.
I had heard that it surged quite quickly and then dropped off. In your case, because you're taking the 5,000 units every day, are you having a handful of Ostelin, or are you taking the Osteovit weekly, or how are you supplementing your big doses?
I'm just having a handful of Ostelin every day, and I've been too lazy to get the injection, to be honest, but I've just got a habit now. I just before I walk out the door, I just take 5 Ostelin every morning, and it works for me. So
I often say to people that maybe if you just take a handful of the weekly once a week, then you can sort of get ahead of the game, particularly for women who've just had babies, or people who don't like taking tablets. The next question is about cementing for vertebral fractures. Is it effective for reducing pain in the early stage?
It's a good question. The answer is yes, I think it is. We perhaps don't use it quite as widely as we did before, because there's been a little bit of controversy about whether it can lead to fractures in the vertebrae around the vertebroplasty site. But in somebody who's got very severe pain, it often leads to a dramatic, fairly quick resolution of the pain. So there is a role for it, perhaps a bit more limited than what it was, say, 10 or 15 years ago. And just to go back to vitamin D just for a moment, just to highlight that, the standard recommendation is, say, 1,000 units of vitamin D3 a day. But if you're deficient, then you need much more than that to rectify the situation. My D level was 20, and I've managed to get it up to about 78 a few months ago with 5,000 units a day. If I'd just taken 1 a day, it'd probably still be 20. So if you've got somebody who's deficient, you need to give them a bigger dose than the standard 1,000 IU per day. And there's minimal risk of toxicity with vitamin D causing hypercalcemia, etc., if you monitor their serum calcium and D levels very carefully. So it's just a matter of watching them carefully, and then you can down titrate the vitamin D dose when their level builds up.
Now, a question about BMD on menopausal women. As soon as a woman reaches menopause, or perhaps if she's had a total hysterectomy with loss of ovaries, would you do a baseline bone mineral density test then?
It's a good question. There are 2 answers to that. One is the Medicare answer, and one is my personal answer. My personal answer is yes, I think it's reasonable to do a bone density at the time of menopause or hysterectomy or surgical menopause, and that's especially if there are other risk factors for osteoporosis such as family history. But unfortunately, as you all know, bone density is not covered by government for everybody unless you're over 70. So there is that sort of problematic group between 50 and 70 who don't qualify for a bone density on Medicare. But in that situation, you can generally get a non-Medicare bone density fairly cheaply at one of the local nuclear medicine practices.
Now, a lot of your patients, we often see some fancy tests that GPs may not know a lot about. So can you tell us about the role of the urine DPD test? And there's another urine that you order as well that I look at it and go, I've got no idea what that means. I'll just wait until you put it in your letter.
That's the only one that I order. I try and keep it simple, and that looks at osteoclastic function. So it looks at bone resorption and bone turnover. And I find it actually quite useful to follow in people who are on therapy. Say, for example, you've got somebody with osteoporosis and that DPD to creatinine ratio is elevated. That implies bone loss, ongoing bone loss. So it's another bit of information that you can follow over time. You start them on denosumab or Prolia, and 6 months later, that's gone back to normal. That implies that the drug is working. The other situation where it's, I think, helpful to look at that is in a patient who's been on a bisphosphonate for 5 years. You give them a drug holiday, stop the drug, and then, of course, you're going to follow bone density, but I think it's also reasonable to follow that because that will give you a clue there may be an increase in bone loss, that the effect of the bisphosphonate is wearing off, and that a resumption of some type of osteoporotic therapy is called for in that situation.
So maybe you covered this in the slides, but I'm not too sure. If you've had your denosumab you've had your Prolia for 5 years and you've had your drug holiday, when can you resume it or start something else? So let's say I'm 40, let's say I needed to commence Prolia, would I be able to take it until I'm 90?
Well, the answer is yes. Prolia is different to the bisphosphonates. We don't advise a drug holiday in patients who take Prolia, simply because if we do, then there's ample evidence that that leads to rapid bone loss and maybe an increase in fracture risk after stopping the Prolia. So you either take that lifelong, or if you're going to stop it for some reason, like side effects, you would give something else like a bisphosphonate. And I guess the issue of taking a drug potentially for the next 50 years comes up. And all I can say in that situation is that if you started Prolia in 2020, the drug's been around for 13 years and we've got 13 years of experience ahead of where you are right now. So if something pops up in 10 years' time that it causes some dramatic side effect, then you'll be ahead of the game, and we can stop it before it causes that sort of issue with you.
So can you tell us what the difference is between a DEXA and a CT BMD?
Yep. Okay. Well, DEXA uses simple X-rays and it gives you a two-dimensional look at the bone in question, be it the vertebrae, L2 to L4, or be it the femoral neck. CT is CT just of the vertebra, and as I said in the talk, it also gives you a measure of bone density, but it measures the bone density specifically in the vertebra, and you get away from the artifact that you often see, especially in elderly people, of degenerative change, which makes the bone density look a lot better than it really is. It gives you a falsely high reading. So if clinically the patient has osteoporosis and they're fracturing, but their lumbar spine bone density is normal or even above normal, then a CT bone density may be helpful in that situation, and it may even guide therapy, A, in terms of whether you start a drug like denosumab, or B, if the patient keeps fracturing, whether they qualify for teriparatide or Fortea.
So we've only got a couple of minutes left, and I think the final question, unless anyone else is going to send anything else through to Bertha, but I think we're nearly done. Do you think it's better to take a stable dose of vitamin D every day, so whether that's 3,000, 5,000 units, or just take mega doses for the 3 months of winter? Now, I must say, I'm probably in that winter camp, like as in I'm out in the sun for a good 6 months of the year, and I then notice that my vitamin D drops off over winter. Are you better off to take a consistent dose or a winter mega dose?
It's a very good question, and I'm not aware of any studies that give us the answer to that question. I do have a few patients who just take vitamin D from April till October because I've done their vitamin D level in summer, or at the end of summer, it's been quite good. Do it at the end of winter and it's low. So, there is a subset of patients who do that, but to be honest with you, the majority of patients are like me, and they're just vitamin D deficient all the time.
Mm.
And as I said, that really surprised me because I get at least an hour of sunshine every day because I catch the train to work, and the weekends don't drive anywhere, just walk everywhere. I live in the city and, walk for hours every weekend, and I was profoundly vitamin D deficient, so go figure.
Maybe I'll have
So
to go and talk to your specialist general practitioner about managing your vitamin D deficiency.
I have actually. I have, and I actually have my own endocrinologist as well, so there you go. Well, it was quite funny when I was in St Vincent's with my hip fracture, the rehab team said, "You're very vitamin D deficient and it's 20, how much should we give you?" I felt like saying, "You're the doctors." Anyway, so it's funny being on the other side of the equation.
Yes, I had lots of excited patients that you were still consulting from your hospital bed.
I was. Gave me something to do in between rehab.
Now, we do have a few more questions. So if you've got an adolescent patient with an eating disorder, at what age would you consider doing a bone mineral density test?
Yeah, this is a very, very difficult group because, except in very extreme circumstances, you're not going to be keen on giving these people definitive osteoporotic therapy. I think it's reasonable to do the bone density earlier rather than later because it does give you something to follow. You can, it would probably highlight the need to get on top of things like vitamin D status, and calcium intake, bearing in mind that you can potentially have an effect on peak bone mass in a younger patient under the age of 35 by loading them up with calcium. So you may have a benefit in that, adolescent with an eating disorder in improving bone density by giving them a lot of calcium. So I would do one early rather than, wait till later, but it's a very difficult group. And the problem is that their bone density doesn't always improve with resolution of the eating disorder. And, I inherit these people in their 30s and 40s, and they've still got problems with quite significant osteoporosis. And an interesting variant on that group are, I would call them the over-exercisers. Your elite athlete who exercises so much as a young woman that she develops hypothalamic amenorrhea. And they get a very similar scenario to what we would see in somebody who's got classic anorexia. That they get amenorrhea, they get loss of estrogen, and they get bone loss. And again, that doesn't always reverse. So that's another very important group and also a very difficult group to treat. And I don't think any of us have a good answer as to the optimal treatment of those people except to try and build their body weight into the healthy weight range, get their vitamin D status right, and plenty of calcium.
So this might be the final question. So if my vitamin D is 35 and I go and take my supplements, how many months later would you repeat the test? And if it was then over 50, over 75, how long would I continue supplements until I could potentially stop?
That's a very good question. The answer to that question is I'd probably check after 3 months. The dose I would give would be more than 1,000 units a day in that situation because otherwise you'll be 35 in 3 months. So I'd probably give 3,000 for 3 months and then do the test again. The endpoint you're aiming for depends on your bone density. So if your bone density is completely normal, then I think it's reasonable to aim for a D level of greater than 50 nanomoles per litre. But if you've got osteopenia or osteoporosis, then I would aim for 75, to switch off that theoretical excess parathyroid hormone production and increased bone turnover. And I would continue it indefinitely. Once you're vitamin D deficient, in my experience, you're always vitamin D deficient. And that's backed up by literature, but it's also backed up by personal experience. People come back, haven't seen them for 5 years and they've gone off their D at some point, and they're again vitamin D deficient. One of the problems with vitamin D is being over the counter. People often forget to replenish their vitamin D stocks when they run out. Unlike a prescription, they automatically go and fill the script. So don't presume vitamin D, you've got to follow that up.
Yeah. We did have 2 questions about vitamin K2 and the use of that. Do you find there's any relevance for it for bone health?
That's a good question. I've got a few people who do it and I don't discourage them from doing it. There's a little bit, and I emphasize a little bit of bone density data with K2, but I've not seen any data about fracture reduction. So I think it's a little bit of an industry thing where the vitamin industry, you know, are flogging it. But put it this way, there's no harm in the patient taking it, I don't think, but whether it actually does anything profound to bone density or reducing fracture risk, I think has not been resolved.
Great. Well, I think that pretty much brings us to a close. Bertha may have some final words for us, particularly about completing the finishing activity to get your CPD points. But I'd really like to thank you very much, Steve, for doing the webinar